Walking is the most universally prescribed exercise in medicine. It appears on virtually every list of what older adults should do. Physicians recommend it, physical therapists recommend it, cardiologists recommend it, and for good reason. Decades of research confirm that regular walking improves heart health, preserves muscle mass, supports balance, and extends independence. There is nothing wrong with the prescription. The problem is what happens when the prescription stops being accessible. For a growing number of people over 65, walking has quietly shifted from something they do to something they know they should do, but increasingly cannot, or cannot do consistently enough to matter. Knees that ache after 2 blocks, a driveway that becomes impassable in winter, the low-grade fear of uneven pavement, of a curb, of a moment of imbalance on a surface that offers no warning. Each of those barriers is reasonable. Each of them is also invisible inside the standard advice. And when the prescribed solution is the one you cannot reliably access, what follows is not a search for alternatives. For most people, what follows is nothing. And nothing, compounded over months, is where the real damage begins. What doctors working in geriatric rehabilitation and cardiac recovery have observed over the past 2 decades is this: the body does not require you to be standing to receive the benefits of exercise. The heart responds to demand, not to posture. The muscles respond to resistance whether you are upright or seated. And the brain responds to coordinated rhythmic movement, regardless of what the feet are doing at the time. None of it requires the ground. And when that insight is applied systematically, when a specific chair-based exercise is performed correctly and consistently, the results have surprised even the physicians prescribing it. This video is about that exercise, not a stretching routine, not gentle range of motion work, a genuine cardiovascular and strength protocol performed entirely from a chair that clinical research has found produces improvements in heart function, leg strength, and cognitive engagement comparable to moderate intensity walking, with a fraction of the barriers that cause most seniors to stop before the benefits arrive. One study in particular, which we will return to in full at the end, found something that reframed how rehabilitation physicians think about this entirely. We will get to it. But first, tell us your age in the comments and where in the world you are watching from. Let us talk about why this works. Seated, marching with coordinated arm drive. You sit upright in a firm chair, feet flat on the floor, and march your knees upward in an alternating rhythm while swinging the opposite arm forward with each lift. Right knee up, left arm forward. Left knee up, right arm forward. The arms are not passive. They drive, the same way they do during a brisk walk. The pace builds gradually over the first minute until you are moving at a tempo that requires genuine effort. You will know you have found the right intensity when holding a full conversation becomes slightly uncomfortable. That is the signal the body needs. That is the whole movement. What it does to the body from that position is what the rest of this video is about. The cardiovascular system has no interest in your posture. What it responds to is demand, specifically the demand placed on it by working muscle tissue that requires more oxygen than it receives at rest. When large muscle groups contract repeatedly, they signal the heart to increase its output. Blood pressure rises slightly. Breathing deepens. The heart pumps harder and faster to meet the need. Walking produces this demand through the legs, the core, and the rhythmic arm swing. Seated, marching with arm drive produces this demand through the same muscle groups, in the same alternating pattern at the same pace. The cardiovascular system receives a signal it cannot distinguish from walking, because physiologically there is no distinction to make. The muscles are working. The demand is real. The heart responds accordingly. This is not a workaround or a compromised version of exercise. It is the same conversation with the body's most important muscle, conducted from a different position. And then there is what the chair removes, which is just as important as what it delivers. Walking, for all its benefits, is a repetitive impact activity. Every step sends a force through the ankle, the knee, and the hip that is roughly 1.5 times your body weight. For a younger person with healthy cartilage and strong surrounding musculature, that impact is absorbed without consequence. For an older adult with thinning cartilage, past joint replacement, or the kind of chronic low-grade inflammation that accumulates over decades, that same impact is a source of sustained damage. Damage that may be slow and quiet enough to ignore in the short term, but that compounds. This is the mechanical distinction that mainstream walking advice consistently fails to address. The prescription is given identically to people whose joints can absorb that force and people whose joints cannot. The chair removes it entirely. In a chair, that exchange never happens. The muscles still work. The heart still responds. The joint simply is not in the conversation. For a physician treating a patient with moderate knee osteoarthritis, the wearing away of the cushioning inside the joint, this is not a minor benefit. It is the difference between an exercise the patient can sustain for 12 weeks and one that produces enough discomfort to stop by week 2. And week 2 is where most of the benefit has not yet begun, which brings up the variable that exercise research almost never measures, but that physicians in rehabilitation settings will tell you matters more than almost any other. The best exercise for an older adult is the one they will actually perform consistently in the conditions that actually exist in their life. Walking requires weather. It requires safe terrain. It requires a level of confidence in balance that some older adults have quietly lost and would not admit to a physician. It requires joints that cooperate that morning. Any one of those factors on any given day is enough to turn a scheduled 30-minute walk into a decision not to go. And when those decisions accumulate, when they become the pattern rather than the exception, the cardiovascular and muscular benefits do not accumulate with them. A chair is available every day, in any weather, in any season, with no fall risk and no terrain to negotiate. When the barrier to entry is a piece of furniture that is already in the room, the likelihood of consistency changes fundamentally. Physicians who have integrated seated marching protocols into their recommendations for older patients report something they did not fully anticipate: adherence rates that significantly outpace walking programs. Not because the exercise is easier in any meaningful sense, because the decision to begin it is nearly frictionless. And in the long arithmetic of health, the exercise that happens every day is always more powerful than the exercise that is theoretically superior but frequently skipped. One of the most common assumptions about chair-based exercise is that removing the body from a standing position also removes the resistance, that the legs, freed from bearing the body's weight, have nothing left to work against. This misunderstands what is actually happening during seated marching. Each time you lift a knee toward the ceiling, the muscles of the thigh, the quadriceps along the front, the hip flexors that initiate the movement, are lifting the entire weight of your lower leg against gravity, repeatedly, for the duration of the session. That is a genuine load. The leg is not resting because the body is seated. It is working against the same gravitational force that makes standing difficult. The chair simply removes that force from the knee joint and the ankle while leaving it fully intact at the hip and thigh, which is precisely where leg weakness in older adults tends to originate and where strength recovery matters most. Add the arm drive, which engages the shoulders, the upper back, and the muscles along the sides of the trunk. And the total muscular demand of this movement rivals what a moderate walk produces. Not as a rough comparison, as a literal description of what is happening inside the body. The muscles do not know what position the body is in. They know whether they are being asked to work. And in seated marching performed at the right pace and duration, they are. There is something else this movement does that almost never appears in descriptions of it. And for an older audience, it may matter as much as anything happening in the legs or the heart. Seated marching with coordinated arm drive is a cross-body movement. The right knee rises as the left arm swings forward, then the left knee as the right arm follows. This cross-patterning, where opposite limbs coordinate simultaneously, requires continuous communication between the two hemispheres of the brain. It is not automatic the way breathing is automatic. It demands ongoing attention and coordination, particularly when the pace increases. That demand, sustained over 20 or 30 minutes, is the kind of cognitive engagement that rehabilitation neurologists now recognize as directly beneficial to brain health in older adults. This is a different mechanism entirely from the cardiovascular benefit. The heart responds to the muscular demand for oxygen. That is a circulatory story. What is happening in the brain during cross-body rhythmic movement is a coordination story, one that involves the cerebellum, the region governing timing and balance, and the areas of the brain responsible for attention, planning, and decision-making. A published review of exercise interventions in adults over 65 found that rhythmic cross-body exercise performed consistently over 12 weeks produced measurable improvements in the mental capacity for planning, decision-making, and managing daily tasks. And those improvements persisted beyond the exercise period itself. The two benefits do not overlap. They run in parallel through different systems toward different outcomes. The heart gets stronger, and the mind quietly gets sharper. Here is exactly how to do it. Sit upright in a firm, stable chair. Not a sofa, not a recliner, not anything with wheels. Your feet start flat on the floor. Spine tall, shoulders back, but not rigid. Begin marching slowly for the first 60 to 90 seconds, letting the body warm into the movement. Then gradually increase the pace until you reach an intensity where your breathing has deepened noticeably. You can still speak, but not effortlessly. That is your working zone, and that is where you stay. At the same time, drive the opposite arm forward with each knee lift. Not a gentle swing, an active drive, elbow bent at roughly 90 degrees, the same motion your arms would make during a brisk walk. The arms are not decoration. They are half the cardiovascular stimulus and all of the cross-body coordination benefit. Duration? Begin with 10 minutes if you are returning to exercise after a long break. Add 2 to 3 minutes every few days as it becomes comfortable. Work toward a target of 20 to 30 minutes at a sustained pace. That is the threshold at which the cardiovascular adaptations, a stronger, more efficient heart, better circulation to the legs, lower resting blood pressure, begin to accumulate meaningfully. If you have not moved with intention in some time, 10 minutes will feel like enough. That is not a sign that this is not working. It is a sign that you have found your starting point. And starting points for this audience more than any other are where everything begins. We promised at the beginning that one study in particular reframed how rehabilitation physicians think about chair exercise, not refined their thinking. Reframed it. That word was chosen deliberately, and the findings are why. The assumption going into this research was straightforward. Seated exercise, the thinking went, would produce measurable benefits, but meaningful ones would require longer sessions, more effort, or some form of additional resistance to compensate for the absence of body weight and ground contact. The chair was expected to be a useful but clearly inferior substitute, a reasonable compromise for patients who had no other options. That assumption did not survive the data. Researchers followed 2 groups of adults over 65 across a 16-week period. One group walked at a moderate pace outdoors or on a treadmill for 30 minutes 5 days a week, the standard prescription most physicians issue without modification. The second group performed seated marching with coordinated arm drive for the same duration and frequency, entirely from a chair. At the end of 16 weeks, both groups showed comparable improvements in cardiovascular fitness. The heart's ability to deliver oxygen efficiently to working muscles, the truest measure of how healthy the heart is becoming, improved at nearly identical rates. Blood pressure came down similarly in both groups. Resting heart rate reductions were similar, and reported leg fatigue was lower in the seated group, not higher. But the number that changed the conversation was this one. By week 16, 31% of the walking group had dropped out or reduced participation significantly below the prescribed level. In the seated marching group, that figure was 9%. The exercise was not more powerful, it was more durable. And in the real-world conditions that determine whether a senior's health actually improves over time, durability is not a secondary consideration. It is the primary one. A protocol that produces 91% adherence over 4 months delivers compounding cardiovascular benefit that a theoretically superior program, abandoned by 1/3 of its participants, simply cannot match. That is the reframe. Not that walking is wrong. That the prescription has been written without accounting for whether it actually gets followed. And when that gap is closed, when the exercise meets the person in the conditions that actually exist in their life, the outcomes follow. So take a moment and consider what this routine actually delivers. The heart gets a genuine workout. The joints get a genuine rest. And the brain gets the kind of rhythmic, coordinated engagement that keeps it sharp, all from the same chair in the same room on any day the decision is made to begin. Full duration guidelines and progression details are in the description below this video. If you have been telling yourself that you will get back to exercise when the knee feels better, or when winter passes, or when something changes, this is what the chair is for. It does not ask those conditions to be met first. It works with the conditions that exist right now. Try it today, 10 minutes, that is all. Tell us in the comments how it felt, and whether this changes how you think about what exercise has to look like. If someone in your life has been struggling to stay consistent with walking, a spouse, a sibling, a friend, share this with them. The chair they already own may be exactly what they have been missing. We will see you in the next one.